In oncology, skeletal muscle serves as a vital clinical reserve. A patient's existing muscle mass directly dictates their ability to tolerate toxic anti-cancer therapies and dictates their physiological resilience following major surgery. Ordinary age-related sarcopenia is a gradual, steady decline in muscle tissue over decades. Cancer introduces a distinctly aggressive pathology. This visual compares standard aging with the oncological reality. The degradation steepens sharply when driven by tumor-derived inflammatory signals, localized metabolic disruption, and the stress of the disease itself. Surgical interventions, chemotherapy, and radiotherapy compound the stress, accelerating this tissue erosion past normal physiological limits. The patient enters a severe hypercatabolic and hypoanabolic state. Their body breaks down protein faster than normal while simultaneously losing the ability to synthesize new muscle tissue. Because cancer-induced muscle wasting operates through these aggressive, specific biological mechanisms, it demands active clinical intervention. Passive observation allows the treatment window to close. A 2026 systematic review and meta-analysis published in Frontiers in Nutrition by Zhao and colleagues investigated how to counter this exact process. The researchers aggregated data across 59 randomized controlled trials, creating a robust, diverse dataset of adult oncology patients. They tested a central clinical question: can non-pharmacological interventions meaningfully alter the downward trajectory of cancer-related sarcopenia? In this context, non-pharmacological interventions refers specifically to structured supportive care protocols implemented during or after cancer treatment. The trials were divided into 3 specific categories: programs that used exercise only, programs that provided nutritional support only, and multi-component programs that combined both. To measure efficacy, the researchers tracked 3 primary domains: raw muscle mass, muscle strength, and tested physical performance. The pooled results confirm that cancer-related muscle wasting is a modifiable syndrome. Interventions can preserve clinical reserve and improve functional independence. This dot and whisker plot establishes the baseline effect across all 59 trials for preserving overall muscle mass, showing a positive standardized mean difference of 0.25. This represents a modest clinical improvement, but the confidence interval sits entirely above 0, indicating a statistically significant, reliable benefit. The data becomes highly instructive when we separate the interventions by their specific modalities. Programs relying strictly on exercise achieved an effect size of 0.21. Protocols providing nutritional support alone performed slightly better, reaching an effect size of 0.28. However, multi-component programs combining both approaches yielded the highest preservation of muscle mass, with an effect size of 0.33. This outcome aligns with the underlying biology of skeletal muscle. Structured exercise provides the necessary anabolic stimulus. It is the physiological signal commanding the body to build or preserve tissue. Clinical nutrition provides the substrate. It delivers the precise amino acids and caloric density required to physically execute that biological command. In a hypercatabolic oncology patient, single-modality interventions lack necessary components. Overcoming metabolic disruption requires pairing the physiological stimulus with the nutritional substrate. This data plot tracks the secondary domain of muscle health, raw functional strength, measured primarily through grip strength. The initial pooled data showed an effect size of 0.21. However, systematic reviews must account for publication bias. Journals inherently favor publishing trials with positive results, which artificially inflates perceived effectiveness. The researchers detected potential publication bias and statistical heterogeneity within this specific grip strength dataset. To stress test their findings, they applied a trim and fill statistical adjustment, plotting hypothetical negative trials to intentionally balance out the positive bias. This highly conservative adjustment forced the effect size down to 0.13. Crucially, the confidence interval remains firmly above 0. This means the clinical benefit observed is mathematically durable. Even after applying maximum statistical penalties for missing data, the interventions definitively preserve raw functional strength in patients undergoing cancer treatment. The third clinical domain measured across the 59 trials was physical performance. Overall, interventions showed a positive effect size of 0.29. This split-screen chart illustrates a measurement paradox in the data. The overall positive trend obscures massive discrepancies depending on which clinical test was actually administered. Clinics frequently rely on brief batteries, like the SPPB and 5 times chair stand, but these failed to capture efficacy. The SPPB showed a negligible 0.12, and the chair stand flatlined at 0.02, making both statistically insignificant. These tests are too short and metabolically undemanding to detect the complex physiological shifts occurring in oncology patients. However, the results shift dramatically when we look at clinical tests that specifically evaluate sustained power and endurance. The 6-minute walk distance captured a clear effect size of 0.28, and the highly demanding 30-second sit-to-stand test registered an impressive 0.57, the largest single effect reported in the review. Sustained tasks force the patient to rely on their deeper muscular reserves, exposing the actual metabolic improvements generated by the interventions. This presents an immediate operational directive for physical therapists and trial designers. Measuring success requires the correct tools. Tracking functional preservation in cancer care demands rigorous, endurance-based metrics. Based on this review, standard oncology care must evolve to treat muscle health as an active priority, rather than a passive casualty. This data points toward a modernized clinical pathway built on 3 specific nodes of action. The first pillar is routine baseline screening. Care teams must assess patients using accurate, power-based metrics, particularly during critical treatment transitions. The second and third pillars must be executed concurrently. Nutritional substrate and anabolic exercise stimuli must be merged into multi-component protocols. While the benefit is clear, clinicians must acknowledge limitations. The overall effect sizes remain modest, and trial structures varied heavily. Across the 59 trials, researchers utilized vastly different intervention durations, exercise intensities, and nutritional formulas. The next mandate for oncology research is to standardize these protocols. We need to identify the exact dose and optimal timing required to maximize these clinical gains. The evidence demonstrates that structured, multi-component interventions successfully preserve skeletal muscle mass and functional strength. Active muscle preservation belongs in modern oncology care.